Hello and welcome to another edition of RUMC Vital Signs. My name is Alex Lutz. On our show you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning, full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit www.rumcsi.org. Neurosurgery is the medical specialty that deals with the diagnosis and treatment of patients experiencing issues with their brain, spinal cord, spinal column, and peripheral nerves throughout the body. With me today is Dr. Douglas Cohen, board-certified neurosurgeon, caring for patients at Richmond University Medical Center's Brain and Spine Center. Dr. Cohen graduated from the prestigious Harvard Medical School and completed his residency at Columbia Presbyterian Medical Center. Thanks for joining me today, Dr. Cohen.
My pleasure.
So tell us a little bit about the services that are going on at the Brain and Spine Center.
Well, you know, it's a kind of general neurosurgical department. We cover most pathologies, both intracranially that involve the brain, as well as the spinal cord, spinal column, things like herniated discs, degenerative spinal disease, spinal stenosis, brain tumors, spine tumors, a whole host of things.
So you're not dealing with strokes. It's neurology and neurosurgery are two different areas.
Correct. Actually one that is frequently and understandably confused. But there are components of strokes or types of strokes that neurosurgeons are involved in. They tend to be a small minority of the strokes, hemorrhagic strokes where there's actually blood clots that need to be evacuated, or aneurysmal strokes where there's hemorrhage from an aneurysm. Those tend to go to the neurosurgeon as opposed to the neurologist.
And when you're dealing with that type of a stroke, what exactly are you doing when you perform surgery on?
Well, mostly just trying to evacuate the blood.
Okay.
Essentially, the damage done by the blood clot can be exacerbated by leaving the blood in the brain as it causes more and more pressure effects on the surrounding brain. The unfortunate part about that is there's no reversing the actual primary damage done by the blood clot, but if we can quickly evacuate it, it will at least reduce the pressure effects on the surrounding brain and thereby reduce some of the long-term effects of the stroke itself.
So when you're helping patients in that situation, has the clot already been removed at that point?
No, we are the ones that remove the clot.
Oh, you are, okay.
So yeah, it's a little confusing because when you get a clot in a blood vessel, that causes a stroke. But I'm talking about a blood clot outside of a blood vessel in the brain.
Oh,
it's a blood clot that is actually pushing on the brain that doesn't belong there. It's not clogging a blood vessel, it's actually producing pressure effects on the brain that needs to be relieved.
And how often are you treating patients
like that?
Like that with a stroke?
You know, probably I would say once a month or so.
Okay. But you're also dealing with other conditions of the brain too, right?
Absolutely.
So what are some of the more common conditions that you are actually dealing with more commonly?
Well, as I mentioned, kind of the spinal pathology we had talked about. There are actually brain tumors that we deal with commonly, words called meningioma, glioblastoma, astrocytoma. There are also tumors of the spinal cord itself, and those are potentially treatable by neurosurgery as well.
And for those that aren't aware, the spinal column and the spinal cord are two separate parts of the anatomy, correct?
They are. The spinal column is generally kind of the supporting structure. It's the, if you will, the skull of the spinal cord. So the spinal cord itself is the nerves or the nerve pathways. The spinal column are the vertebrae, the bones, the ligaments around the spine. You might be familiar with things like herniated disc. A disc is a portion of the spinal column that can herniate, essentially move to a place where it doesn't belong and cause pressure on nerve roots, which can cause not only pain but weakness.
So you treat herniated discs?
Absolutely, yes.
I'm assuming that's a very common ailment?
It is. It is relatively common. It comes in a whole variety of different fashions. The good news is many actually don't require surgical treatment at all. We work with a variety of different departments, whether that's physiatry, physical medicine, and neurology, but frequently some kinds of herniated discs can be treated non-surgically and frequently with the help of neurologists, pain management doctors, and rehab doctors.
And when it does come to a point of surgery, what exactly are you doing?
Generally removing the disc. Now, depending upon where that disc is, that can kind of contour the type of surgery that's required. If it's in the lower back or the lumbar spine, it tends to be what's known as a microdiscectomy, where we go in and remove the disc from the back. If it's in the cervical spine, not only can it cause pain and weakness, but it can actually cause spinal cord compression. And frequently disc herniations in the cervical cord, not frequently, but certainly a certain percentage of disc herniations in the spinal cord can become emergencies, because they can actually push on the spinal cord or through the spinal column and cause weakness, difficulty with bowel and bladder function, and even difficulty walking. So those are treated through the front, an incision made actually kind of in the front of the neck, where we go in from in front, not only remove the disc herniation itself, but essentially stabilize the spine with instrumentation, which is something that we commonly do.
Well, that was my next question, actually, and correct me if I'm wrong. If you're removing the herniated disc, the disc is kind of like a cushion, right?
Correct.
So if you're removing the disc, are you fusing the bones together, putting something there?
In the cervical spine, overwhelmingly, yes. We are fusing the spinal canal because in order to remove the disc herniation, we are going from in front. And so to get back to the portion where the disc is herniated against the cord, we essentially have to remove almost the entirety of the disc. And to leave that without any stabilization can be, and was, during the early parts of my training, that we did just the discectomy without the fusion, without the instrumentation, and patients would have chronic neck pain. They would develop what's known as kyphotic deformity. They could go on to develop other pathology of the spinal cord because of that. The lumbar spine, on the other hand, we tend, when it's just a disc herniation, to just remove the portion of the disc that is herniated.
And lumbar is a lower
back. We do not have to remove the bulk of the disc, and therefore, in the majority of those cases, fusion, instrumentation, stabilization is not required.
And how long is the recovery period for that type of a surgery?
Well, you know, lumbar spine, lumbar discs are actually one of my favorite operations, because it's one of the few operations where you go to see the patient in the recovery room, they open their eyes and they say, "I'm better." I mean, it's that quick. They just feel it as soon as they open their eyes. And these days, those patients are going home within an hour or two. The anterior cervical discs are generally still kept overnight. I know some people are doing them as outpatients, but we generally keep them overnight because you're dealing with potential pathology that can develop over that night that I want to keep an eye on the patient for.
And once they leave the hospital, how long is the recovery where they can actually get back to normal, so to say?
Yeah, I mean, essentially they are back to normal by the time they go home. And what that means is essentially they can do most of the normal activities. They need to stay away from strenuous activities, generally for a period of about 4 to 6 weeks. They need to stay away, obviously, from high-impact activities, anything that can expose them to any kind of trauma, whether it be head and neck if they're have just undergone cervical spine surgery, or lower back if it's lumbar spine surgery. But other than that, they can be up, they can be driving, they can, you know, do their normal things. You know, I've had patients who I generally tell after an anterior cervical disc, I say, you know, you've had general anesthesia, there's a little bit of blood loss, you're going to want to take a couple of weeks off of work. I've had patients that have desk jobs who call me back 2 or 3 days after surgery and say, "I'm going crazy, can I go to work?" And I say, yeah, sure. There's nothing dangerous about it. I wouldn't let a construction worker go back to work in 2 or 3 days. But, you know, there's really nothing other than strenuous activity that you can't do within a day or two after the surgery.
And it sounds like a complicated procedure. How long is the actual surgery?
You know, a single-level anterior cervical discectomy runs generally about an hour to an hour and a half. A lumbar laminectomy, a single-level microdiscectomy, is about the same, about an hour, sometimes a little bit less. Things can get difficult, and when you're doing multiple levels, that can obviously make the surgery a little bit longer, but generally only a couple hours.
And is this performed with open surgery, or are you using robotics to help?
Neurosurgery is one subspecialty that we don't, or at least I have not really used robotics. I see it in the literature now. There are components of surgery for seizures that is done robotically, but in general, for the most part, neurosurgery, it's done through a microscope, it's done through minimally invasive openings, but it is not done robotically.
Okay. And you mentioned before about tumors around the brain. I'm assuming you're dealing with both cancerous and benign conditions?
Correct, yes, absolutely.
And when you're in, do you sometimes, I mean, are you aware when you go in that this is a cancer situation, or sometimes discovering that while you're there?
You know, one of the, real significant advances, and it's not really even an advance anymore, it's now about 20 or 30 years old, but one of the significant advances in neurosurgery is actually the application of neuroradiology. And now with the MRIs, the sequences that we have, we can be almost certain of a particular diagnosis, whether a patient has a malignancy like a glioblastoma or a more benign tumor. I always tell patients, look, we can't be absolutely 100% certain unless and until we have a little piece looked at under the microscope, because pathologic assessment is the gold standard. That's how you make a determination. This is a meningioma, this is a sarcoma, this is a glioblastoma, an astrocytoma, they're all, but we can really go a significant percentage of that in that direction, sometimes as far as 90, 95, even 98% just based on the MRI. So overwhelmingly likely, you have a pretty broad idea of what most of the tumors are that you're operating on. There are always some that are a little bit confusing, interesting, have components of one tumor in one sense and then on a different sequence another one, so you can't be absolutely certain. But you have a very good idea based on the radiologic assessment alone of what you're dealing with.
And I guess as a patient, the idea of having brain surgery can be overwhelming. How do you have those conversations with patients where you're preparing them for surgery, getting them ready, getting them prepped?
Yeah, I mean, you know, my kind of my threshold in the way I kind of explain this to patients is, you know, I can't guarantee that what I'm recommending has no risk. Sometimes it can have an exceedingly high risk. But the reason why I recommend it is because the alternative has an even greater risk. In other words, this is something that has to come out. It's not something that, you know, is going to go away on its own. It's only going to get bigger and be essentially riskier, you know, 6 months from now. So, you know, you try to let them know, you know, very honest and very transparently about what they will be exposed to and what we're going to be dealing with. But the recommendation is because this is, you know, far and away the best choice. This is the best option, and that's why it's really the best thing. It's not because it's easy and not because it potentially doesn't carry risks, but because the alternative, essentially not doing the surgery, carries much graver risks.
So the benefits are outweighing the alternative.
Far,
as you said.
yeah.
I see. And what are some of the, I'll say, less common conditions that you're treating?
Well, let's see. You know, trigeminal neuralgia is something, a specific type of facial pain that we can treat that about 25 or 30 years ago they discovered really is the result of a blood vessel pushing on a specific cranial nerve. So what we do is we go in and we essentially put a little cushion, a little pad between the blood vessel, through a microscope obviously, this is all kind of right around the stem of the brain, and by taking that pulsating blood vessel off of the nerve, the pain goes away. Trigeminal neuralgia is something prior to surgical treatment that people would, it's such a painful syndrome that people would commit suicide. So this is, you know, obviously something that we're very happy that we can treat effectively now.
And is it a particular blood vessel that's present on the
It
brain?
generally tends to be a particular blood vessel. It's called the AICA, but it's the it can be a variety of different ones. It can also be a vein, but it is always a single cranial nerve. It's the cranial nerve that transmits sensation to the face.
And is this a genetic condition, or is this?
No, it's thought to be kind of degenerative in that with time, you know, our blood vessels tend to get loopier and longer, and with things like atherosclerosis, they can get more dilated, and as that happens over time, so we call it degenerative, but I'm not saying, you know, you're out there playing football with your blood vessels.
Right.
It just over time, and as you get older, things get worse. It tends to happen more commonly in the 6th and 7th decades of life.
I can't imagine pain so bad that you can contemplate suicide. I mean, obviously that's, and all it takes is a cushion and that.
Yeah, I mean, look, there are other causes for trigeminal neuralgia that can occur in the setting of multiple sclerosis when there is not a blood vessel that is pushing against there. There are other things that can cause this type of pain syndrome that are not effectively treated by putting the cushion between the blood vessel and the nerve root. However, absent multiple sclerosis and several other very kind of uncommon pathologies, the overwhelming majority of the patients that have this kind of pain are treated effectively and essentially cured of their pain with that procedure.
How common is the condition?
It's very uncommon, thankfully.
But you've seen it.
Oh yeah, seen it and operated on it.
And
absolutely.
aside, I mean, obviously the pain seems to be the number one symptom. Well, are there other symptoms of this?
No, that's
really?
one syndrome, one pathologic entity that is really pain. It is that blood vessel kind of hitting that cranial nerve, the fifth cranial nerve, right at a location where it can be irritated and causing this kind of, it's known as lightning or lancinating pain, this kind of lightning bolts of pain into the cheek and chin.
Wow. That's and it's just a cushion is all it takes to take this.
Well, what it takes is you got to get that blood vessel off of. It's thought that the pulsatility right at this location. It's not at every location along this cranial nerve, but right at this specific location can cause the axons, the nerves within the cranial nerve, to fire and cause this kind of pulsing, lancinating, lightning-like pain.
And is it a particular part of the face, or it could be anywhere?
Yeah, no, that's one of the classic kind of distinguishing characteristics of trigeminal neuralgia. The reason why it's called trigeminal neuralgia is the cranial nerve is called the trigeminal nerve. It's there's three separate roots. One is basically your forehead down to the level of your eye. The second is the cheek from the level of your eye down to the corner of your lip. And the third is the chin below the lip. And that's where those three divisions go. So trigeminal neuralgia classically will be this lancinating, horrible pain, but only in one of those distributions. So when you have a patient who has the pain that only goes from their lip up to their eye, you know that that's in what's called V2, or the second branch of the trigeminal nerve.
Is there one more common than the others, or?
It tends to be V2 and V3. I think it's probably, V3 is the chin. It's very uncommon in the forehead, but it possibly is. And that's thought, by the way, anatomically, because that blood vessel that tends to be the one that bothers it comes up from the bottom. And so in coming up from the bottom, it's more likely to hit V2 and V3.
And how do you surgically go in to do this procedure?
What we do is we have to do a craniotomy, which is kind of removal of a small window of bone, actually in the corner in the back.
Okay.
And then we go kind of the incision and the removal of bone is behind the ear. And then we kind of skirt along the side of the brain stem to where this fifth cranial nerve is being irritated by the blood vessel.
Oh, okay. Just so make it clear you're not entering through the face of the person.
No, from the back, actually, coming to in front of the brain stem, but the approach is from the back.
And how many cases have you dealt with in your career in this particular condition?
You know, several dozen. Not a ton.
Okay.
But yeah.
But it sounds well. Thankfully, there's a I'll say, no, I won't say a cure, but there's a treatment for it. Is it a cure?
No, that is a cure.
It really is.
Yeah,
oh, okay,
I mean,
okay.
you know, there were other treatments called rhizotomies where you go in and burn the nerve, essentially just numb the patient out. But there is a certain percentage of those rhizotomies that the pain can come back and actually come back much worse. Something called anesthesia dolorosa, which is essentially untreatable and it's miserable, and we don't even want to get into that. But now that we can do this kind of decompression, there is still a recurrence rate, just like when we do a disc herniation, but the lion's share, the overwhelming majority of those patients are essentially pain-free for the remainder of their lives.
And what is the cushion made up of?
It's kind of a Teflon. It's really kind of like a material that is just kind of some woven Teflon that we can put in between.
Well, good to know that if it happens, that people have a place to
Yeah,
go.
way out. Yeah, absolutely.
So we talked a lot about conditions, but obviously I'm thinking in the Brain and Spine Center and in your career, you're dealing with a lot of traumatic brain injury as a result. How do you approach the victim of a traumatic brain injury as opposed to someone who's coming in with a condition?
Yeah, I mean, you know, traumatic brain injury is a condition. It's just a particularly acute condition, meaning it happens suddenly and frequently does require, you know, very quick, potentially life-saving intervention on the part of the neurosurgeon, you know, in the middle of the night sometimes, depending upon, you know, when the car accident was or when the fall occurs or things like that. There is a significant percentage of patients who sustain closed head injury that don't require surgery, but do still require very invasive, not very invasive, but very intensive and partially invasive procedures like intracranial pressure monitoring or something called ventriculostomy, a drainage of fluid from out of the brain. These are all things that there can be done bedside procedures, but the surgical intervention is minimal. The most important part is kind of the medical management of these patients, and that's something that I do in concert with the surgical ICU team. Obviously, we have you know, a level 2 trauma center, so everybody is very kind of aware of the more common and the most important interventions, whether it's administration of particular medications or what are called hyperosmolar fluids to draw water out of the brain and reduce intracranial pressure. But that is really not surgical. It's something that I do in concert with the surgical ICU team because these patients do frequently require surgical ICU observation and treatment for days and even weeks sometimes.
I mean, I always find it fascinating with talking with yourself and your colleagues when you're thrust into these emergency situations. So walk us through, when you get that call that there's a traumatic brain injury in the ED, what is the information that you're looking for first, you're digesting, I'll say, first, and then how are you going about the physical exam to determine what to do next?
Yeah, I mean, a physical exam is a physical exam, whether, you know, I come to do that, whether a PA is reporting, a physician's assistant is reporting those results. The two most important components of that are the history. In other words, what has happened to this patient. If they've gotten in a horrible accident and they're in the bed talking to you, then it's not likely that there's anything significant or severe going on in their head. They can have spinal trauma, but that's a separate issue. So the two most important things is just the history, what's happened to the patient, what they can explain to you, and the radiologic assessment. I mean, overwhelmingly now, in the setting of trauma, whether it's head or spinal trauma, a CT scan and potentially an MRI is going to answer the question as to whether or not there is a surgical lesion that needs to be treated, whether surgical treatment needs to be pursued and urgently in a person's case. That's because a CT scan will show us if there's a blood clot, a CT scan will show us whether or not there's any kind of specific or significant fracture of the spine, of this, again, the spinal column that can potentially cause pressure of the spinal cord, which could cause weakness and even paralysis if not quickly decompressed.
And as you said, as a level 2 trauma center, I'm assuming you also get a percentage of patients that are unresponsive. So in those instances, it's the technology that you're really working?
Well, it's, you know, it's the CT scan is going to answer. There's a whole host of reasons why a patient might be unresponsive. Certainly after trauma, those are of graver concern. But, you know, unfortunately, you can get a drunk driver who gets in an accident and they're unresponsive because they have a high blood alcohol level. Those are answers that we'll get based on blood tests, but also we'll see that a CT scan of the head is actually quite benign, that there's no intracranial hemorrhage, that there's no skull fracture that could be a source of this, and so we get to call the dogs off. On the other hand, the CT scan that does show something like that, shows what's known as a contusion or essentially a bruise in the brain, might indicate that we do need to do surgery.
And you've been practicing for how long now?
God, I don't remember. About, well,
so it's the one that stumps. It's the one question that stumps everybody. How long have I been practicing
25 years, almost 30 years.
And we talked about just now about the technology. How has the technology and the neurosurgery field changed from the time you entered it to now?
You know, there are significant advancements in, I refer to spinal instrumentation. When I was a resident, we did not do spinal instrumentation. We did not put metal or titanium into the spinal canal, well, not in the spinal canal, but into the kind of supporting structures, the vertebrae. We do that now regularly and routinely. As I mentioned, the kind of advances in radiologic assessment is also something that really has advanced our ability to treat patients. And then, you know, kind of more in fits and starts, but we end up with a better, something called a Cavitron. It helps us remove tumors now, a Sonopet, which is a better version of that allows us to remove things that are potentially more difficult to remove or would have been more difficult to remove without it. The optics in a microscope improves. There are now ways to determine intraoperatively through the microscope. You can actually differentiate the parts of the brain that are actually infiltrated with tumor and the parts of the brain that are normal. It is unfortunately surprisingly difficult to make that differentiation just based on human vision alone. As you know, in other organ systems, there's a specific type of procedure in dermatology called a Mohs procedure, where essentially they just kind of shave away at a tumor until the pathologist says there's no more tumor cells in that last little shaving. Essentially, you can't tell where the tumor ends. You have to send these pieces off to somebody who looks under a microscope and says, okay, you can stop now, there's no more tumor. In the brain, you can't do that. But there are now technologies and techniques. There are medications that can be administered that can allow the tumor tissue to light up, so that we can tell the difference between normal brain and pathology.
And what drew you to neurosurgery?
That was an interesting and kind of long and somewhat meandering course. I actually went to medical school thinking I wanted to be a psychiatrist. Until I realized that that is not something I wanted to do, but I remained very interested in the brain. I actually took some time off of medical school and did some research in a lab, actually in head trauma, and I became very enamored of that. And, you know, more importantly, you know, we say this so much that it's becomes almost banal, but, you know, the part that we don't have neurosurgery residents at Richmond University Medical Center. We have general surgery residents. But when I was a resident and when I trained residents, the one thing that you can't really teach is the ultimate responsibility for literally saving a life and sometimes not doing that. But that is an incredibly rewarding component of, you know, going to work every day, that you can literally save somebody's life, that their family are incredibly thankful and grateful, and that's, you feel like you're making a difference in a big way.
And tell us a little bit about your colleagues and the staff of the Brain and Spine Center.
Right, so we've had very recent kind of changes in the department. I am joined by a couple of really excellently trained neurosurgeons. And like RUMC itself, we are very much looking to expand. We are looking to expand the footprint of neurosurgery in Richmond University Medical Center. We are looking to expand the type of treatments that we can offer in the Department of Neurosurgery, the Division of Neurosurgery. We're thinking of working with a pediatric neurosurgeon, something that we haven't had here in quite some time. But Dr. Moore and Dr. Weintraub trained at Columbia, went to Harvard, went to medical school at Columbia. They're excellent surgeons. I've operated with both of them, and I'm very excited to have them joining the team.
Great. Well, thank you for taking time to be with us today, Dr. Cohen. So I want to thank Dr. Cohen for joining me, and thank you for all that you're doing to keep the community safe and healthy. Richmond University Medical Center has cared for Staten Island and the New York metropolitan area for nearly 120 years. You can help ensure that care continues for decades to come by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or in honor of a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the Donate button located on the top of the homepage, or you can call 718-818-2106. In the meantime, that just about does it for this episode of RUMC Vital Signs. Thank you for joining us. I'm Alex Lutz. Stay healthy.